And I'm going to talk today about effective addiction treatment. In particular, I'm going to give you a status report on how drug courts are doing on one of our biggest challenges, and that is being sure that men, women in our drug courts have access to the full range of effective treatments, and that includes, for those who need it, medications in addiction treatment. I'm going to give you a status report on that, let you know where we are, and challenge you about where we need to go next. But in many ways, I think it's important to pause just a moment and think about, the opiate epidemic and the increase in overdose deaths that we're seeing. And while there is very little that is hopeful and positive about the epidemic and the overdoses, but the one thing that it has done is it has put a different face on addiction. That ironically, in many ways, the fact that the epidemic, the rise in opiate use and opiate-related deaths is so widespread that it crosses across every racial, ethnic group, every demographic group, that it doesn't fit any of the stereotypes that people have about what addiction is and what it looks like, that it has perhaps provided a fresh opportunity to remove stigma. And that's a positive thing. And so part of what I want to do today as we talk about effective treatment in drug courts and effective responses to the opiate issue when it presents itself in a treatment court population is to be sure we are clear on what's really happening, that we don't get confused with the myths about what this epidemic is and what it isn't. I suppose the first thing I want to say is that we really do have a serious problem. That sometimes, media and other hype issues, that's not really what's happening here. We'll look at some quick stats in just a moment that demonstrate that especially as it relates to opiate overdoses, there are increases that are significant across all kinds of groups. Let's look at some of that. So just since 2010, and even this data is a little bit outdated, since 2010, we've seen tremendous increases in drug-related deaths in that age group you're seeing there in nearly every racial and ethnic group and in almost every state. In 2015, 52,000 Americans died of drug overdose, and that was a 200% increase from just 16 years previous. And 33,000 of those 52,000 deaths were related to opiates. So opiates are still the primary driver of overdose deaths. But I should pause here. So I'm pausing here. Because if 33,000 of those deaths were opiate related, that means that what? That means that what? Do the math or read the screen. One of the two. That means that the 19,000 were not. They were overdoses caused by some other drug. That reminds us that even as we exercise and demonstrate this important and necessary focus on opiates, we don't forget that the other drugs didn't go away. That there's a problem in every drug court and a problem in our community. I was in Atlanta for the prescription drug abuse for some summit, some conference earlier in the year. And I know Atlanta well. I've done lots of work there. And I wonder if crack cocaine is still around. So I decided to go looking. No, don't let that concern you. I know the city. I stayed right downtown. I know the city, and I thought, I'm just going to go drive. And I arrived late at night, so that was convenient. I said, well, it's nighttime. I'm going to ride through the areas where I remember, people were openly selling and using and smoking and getting high. And I said, things. So I drove through that part of town, and, things were very quiet. I said, wow, okay. maybe we've tightened stuff up. Maybe we're done with crack and meth and all that other stuff. But then I noticed, oh, wait a minute, this boarded up building, didn't this used to be a homeless shelter? Oh, this used to be a homeless shelter right here. Oh, they shut down the shelter. So I drove a little further, went a few blocks around, made a couple turns, and just before I was about to give up, lo and behold, I saw somebody smoking a pipe right on the corner. That could have been meth in there, could have been crack. And as I drove further, I could see that we're not done with the problems with crack and meth yet either. So even as we focus on opiates, we can't forget the fact that substance use is widespread and all of the substances need our attention. There is a myth that this is only a problem among white people. Now it is true that some of the increases we're seeing are hitting the white populations harder, but it is worse outside of cities. It is worse outside of cities, and it is hitting white populations harder, but all populations have seen increases in opiate use and opiate-related deaths. You can see some of the information on the screen. A 325% increase in opiate-related deaths in rural areas, 500% increase among our native populations, but rates have also doubled among African Americans. So this really is an opportunity for an equitable response to an issue that is hitting all of us. You see the states there with the highest risk, but every state has been impacted. So this is an issue that impacts us all, and an effective, fair, humane response is required. Now, this is the best data we have, and this is from the last Painting the Current Picture survey, where we looked at the extent of substance use by substance in the different populations. And you can see here that at that time, during that report that was reported out, I think in 2016, but it's probably 2014 data, that 22% of urban drug courts reported that about 22% of their population reported opiates as their primary drug of use. Doesn't mean it's their only one, but it's their primary drug. The primary issue was an opiate use disorder. That was the case for about 31% of rural drug court participants and 34% of suburban. So yes, higher rates in rural and suburban, but again, a significant part of the population in all of these courts. The last really good study we had on how we're doing on our response to opiate use, in particular, our inclusion of medications in addiction treatment in the drug court community, was a study done in 2012. We need an update to that, because I'm confident that the update will look different. But just in the 2012 study, it was encouraging to see, in one extent, that about 76% of urban drug courts, 58% of suburban drug courts, and 45% of rural drug courts allowed some form of medication in addiction treatment, one or more of the 3 addiction medications. So I wish that looked better, but it's certainly better than what anyone can get anywhere else in the justice system. A person has a much better chance of receiving, even back then, of medications in addiction treatment in a drug court than they do anywhere else in the justice system, or for that matter, if they're just on the street and walk in and try and get treatment, they have a better chance of being able to have the benefit of medications if they need that in a drug court than elsewhere. And I wish we could just pat ourselves on the back and keep it moving. If we looked a little closer at what that really shows, that if we ask, instead of do you allow any MAT, but when we ask do you allow all MAT, those numbers would have been much smaller. If I'd said do you allow methadone, the numbers would have been much, 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 much smaller. So we still got some work to do. There's some reasons why some drug courts today are still struggling, back then and even today, are still struggling to to fully implement, to allow their participants the full access to whatever treatment they need, including medications. And in this study, it was concluded that it is really probably one of three things. It's about access, it's about awareness, and sometimes it's about attitudes. And I want to spend the rest of the little time that I have really looking at those three areas, those three barriers, and how drug courts across the country are facing those barriers and coming up with ways to provide people what they need. So we'll talk about some of those barriers and those solutions. So those are the three barriers that I believe are out there. This is based on what our study showed and what I've seen, that it's about access, it's about awareness, it's about attitudes. Access is just like it sounds, that sometimes, even if we have policies that says, listen, people, if they are assessed by someone trained to do so, if a physician who is trained in addiction medicine and is able to assess this individual, and that participant agrees that yes, this is a regimen that I want to be a part of, then many programs say, well, absolutely, we would accommodate that. But in some communities, access is a problem, that they can't find providers to, either they're not near a methadone clinic, or they don't have providers who can administer Suboxone or extended release naltrexone. And so it's about access. And that's not a problem that's just related to the drug court world. There are very few drug courts that exist that have their own independent treatment resources. There are some, but very few. Most of us are limited to the resources that exist in the communities around us. And most treatment providers are limited to the resources they have within their own program. And so it's not just about the drug court world. In fact, I don't know how well you can see that, but just you can see the colors. And the darker blues suggest a higher rate of opiate use disorder in those states. So the darker the blue, the higher the rate of opiate use disorder. And then the size of the yellow circle, indicates the treatment capacity in those states to deliver, if when needed, the medications, the agonists, methadone and partial agonist buprenorphine or Suboxone. So the bigger the yellow circle is, that's the greater availability of medication-assisted treatments with those two medications. And well, first of all, if you actually look at the numbers, even the big circles doesn't suggest great availability. Even the big circles is nothing to be happy about. But notice the tiny circles in some of the bluest states. The tiniest circles in some of the states that have the biggest problems. And there are drug courts in every one of those states trying to comply with the best practice standards. Drug courts in each of those states trying to find services that people need, including those who need medications, in addition to all of the other treatment that they receive. So the problem is about access, and it's not just related to us. Now let's talk about resources for just a minute. Let's talk about resources, because that's what this is about. And in an ideal world, when we established our drug court, we would be very certain that we had all the resources we need to do what we need. In some instances, though, especially if you think about the drug court field, we started in the late 80s, early 90s, and at that time, what was the primary drug that was driving the criminal justice system crazy? What was filling our, oh, wait, check that out. Look at that carefully. Look at that carefully. Never start a project unless you have all the resources available. That's true in an ideal world, absolutely. When many drug courts started, the issue was crack cocaine. There are no medications that are FDA approved to treat that, so we developed relationships with providers who deliver services that don't include that. When the opiate epidemic came and caught us by surprise in some ways, many of us were caught with their pants down and not able really to respond, didn't have the right resources. And what then sometimes happens is because of that, you have people, you're afraid of them ODing, that you end up believing that this is the answer. You know, I've had people who I work with who legitimately are concerned about the fact that this person, I've heard about all these opiate overdoses, and I just feel like I got to lock them up in order to keep them alive. And I just want you to see those words, and I put them in as big a font as I could so that we'd be very clear about that. I'm very sensitive to the fact that sometimes, you know, in the very small print of the standards, the tiny, tiny print acknowledges there are rare instances where, a judge might, based on advice from those around him or her, might have to make a decision to place a person in detention for, their own good for a brief period of time while they're securing treatment. But it says that should be rare and not the matter of regular business. And for some drug courts, that is the matter of regular business. And so I don't have time to give all the solutions to it, but if you don't have the resources you need, a person's not stopping, it's an opiate issue, you're concerned about them overdosing, the first question I would ask you is your program making available to them all 3 of the FDA-approved medications that treat addiction? Because if you're not, then that's the first problem. The best way to avoid opiate overdose, the best way to keep people alive long enough for drug court to work is if those who need medications, be sure they have access to that. So if you are a program that is jailing people, for their own good because they can't get in treatment yet, and they have opiate use disorders, and you're not allowing full access to the medications, then your issue is right there. You need to be sure they have available to them as best you can the full spectrum of what they might need. But the resource issue is a problem for many courts. Sometimes it's about the access. And I want to share with you what some communities are doing to help address that. One is telehealth. We'll look at some examples of that, of how some communities, especially in some of our rural states, are finding ways to access treatment, including physicians who can oversee medications in treatment using telehealth. We'll talk about some examples in just a moment. The reality is drug courts are fighting back. We have seen from our office in Carolyn Hardin's shop and throughout our operation a dramatic increase in requests for training and technical assistance related to medication-assisted treatment. And our offices are doing all we can to produce the resources you need to help you know how to fully implement a medication protocol in your drug court. We have sessions on that at this conference, resources that are out now and resources that are coming. I am eager, Doug, for a new study to add to that 2012 study. I'm confident that we will find the numbers of drug courts that include now medications as among the treatment services that can be included will be dramatically increased. I can't prove that yet, so I have to keep using those 2012 numbers. But everything we are hearing, everything we are seeing is that there's very few drug courts now that are concerned about, well, why do we need to do it? It's about, well, how do we do it? And so we're trying to help with that. It's been a big focus of this conference and elsewhere. Since 2016, NADCP has partnered with the American Academy of Addiction Psychiatry to produce an online course and other resources to help better bridge, really, the gap between addiction docs and drug courts and to help drug courts connect with addiction docs. We have a set of new pocket guides coming out later this year to help with that. The reality is drug court is about evidence-based treatment for all, and that includes medications in addiction treatment when that is necessary. Let me be very careful here to say several really clear things so we don't misunderstand. There is no drug court that should be, as a matter of blanket policy, prohibiting any of the addiction-approved medications. That should not be a blanket policy that says we don't accept those. If you can't access them, that's a different issue. A person receiving medications to treat addiction, one of the 3 that are FDA approved, that they're being actively receiving those medications should not impede them getting into drug court. It shouldn't impede them progressing through drug court, and it shouldn't stop them from completing drug court. Most individuals with opiate use disorders, with severe opiate use disorders, who are receiving methadone or Suboxone or extended-release naltrexone will at some point want to taper off of those. At some point they'll want, in most cases, they'll want to be in long-term recovery without medications, but that's not a requirement, and it's really not our business to make that decision for them. The best outcomes are still for individuals who have severe opiate use disorder to be maintained and stabilized with medications for as long as they need that. With that said, there is a growing consensus among drug court legal experts and drug court medical experts that we shouldn't be requiring people to go on medications, because that can sometimes happen. You go from one extreme to the other. Well, if this is an evidence-based practice, if this is the best approach, then anyone with an opiate use disorder, we will require them to be on this medication or they can't be in the program. That's a problem too. If the participant, if this is the only drug court available to them, they have an opiate use disorder, they're not interested in medications, then they shouldn't be prohibited from going in that program because they don't want medications. There's a growing consensus that the response to that is because medications are different, because they are different than other kinds of therapy. It is a bigger decision, and a participant who is a patient has a right to decide, do I want medications? If they say I do not, then they should be required to participate fully in the other treatment interventions and given the full opportunity to benefit from those. If they cannot establish abstinence and maintain that without the medications, then you are dealing with the fact that they are not getting, not making progress. And any sanctioning you have to do or decisions you have to make is not because they won't take medications, but because they're not responding to the treatments and there's not much else you can do. So you shouldn't be banning medications, nor should we be requiring them. Either extreme is a problem. What we really want is that no one dies from overdose while they're waiting to experience the empowering benefits of drug court treatment. I mentioned we have some new resources coming, 3 new pocket guides, the first ever specifically for drug courts as they attempt to implement medications in addiction treatment. One for the drug court counselors, drug counselors, and other clinicians in this room today. A second pocket guide on medication and addiction treatment for all the other people on the team. And a third one written for and directly to participants and their families, so they can make informed choices about the options that are available to them and decide what they want to do. Finally, let me just highlight a couple courts that are doing some things you should know about. In Buffalo, New York, they've opened what we're calling they're calling kind of a Buffalo opioid court. This is really a rapid assessment, rapid response component of their court system for individuals who are assessed with opiate use disorder and or at high risk for opiate overdose. The criminal matter is placed on hold. They are almost like an emergency triage. They are triaged and placed in treatment immediately, even before decisions made about drug court or probation or anything else. And once they are stabilized and able to do so, then a decision is made about what to do with their matter, including if they're appropriate for drug court or some other part of the justice system. But it's about getting them help right away so they stay alive long enough for the criminal justice system to work, for us to decide who needs to come in drug court so people don't die while we're trying to get our act together. And for those who are not placed in residential treatment, they are coming to see a judge every week in order, or every day, is that right, Carolyn? Every day to see the judge if they're not in residential treatment. Another program, the 13th Judicial District Court in Billings, Montana. Meth is their primary issue, but they also have a big opiate problem as well. They have 2 major hospitals and many other medical facilities, but they couldn't find any provider interested in medication-assisted treatment, none. The nearest doctor was several hundred miles away, so they turned to telemedicine. They have their own Polycom secure video system available to them, and aside from one visit in person by a nurse practitioner to the facility, all medication monitoring and other services is done via the video conference. They also provide the full spectrum of other treatment services as well. Another court in Montana, the 9th Judicial District Court, meth, the big issue, but also opiates are a problem. Their nearest provider was 86 miles away. This is the provider not just for MAT, but provider for any kind of treatment. So they had that provider coming in once a week to do groups and individual sessions. It became too expensive. They couldn't do it. So that court bought a smart TV, used Zoom video call technology or the application, and those providers began delivering drug court treatment groups via video conference. All of the participants gather, the coordinator is there as well, and the therapists are on the monitor, and they've been delivering effective treatment that way. Drug court specific groups, as well as drug court participants joining some of their other groups. And the coordinator wanted me to say this to you. She wanted me to tell you that she'd pondered doing this for 2 years before she finally did it. She was so afraid of how it would go, and it has been far more successful than she'd ever imagined. I wish I could talk about all the others. Cleveland, Ohio, back in 2014, sent a press release out indicating that they were incorporating Narcan, providing Narcan kits to all participants and family members if they are at high risk for opiate use overdose. That was back in 2014. A court in Minnesota has a card that helps people know how to avoid heroin overdose. Drug courts are responding in big ways. The biggest obstacles continue to be the barriers that exist sometimes in our own awareness and our own minds and our own biases, and that's where our challenge lies. Let me end with this, folks. Real voices from real people dealing with this real issue. Here's a person who wrote this note. Please don't get upset or mad at me, but really, I can't move back home right now. Everywhere I look is a trigger for me. And if I move back home, I'll go back to the needle, and that's the last thing I want. Another message. I'm sorry, Mom. I hate my life so much. I'm miserable. I feel like I'm stuck. I hate it more than anything in this world. And I hate to see you hurt even more. The mother says, what can I do to help you? Get the help you need. Anything. I don't know. And that's what bothers me so much, because I have always been in control of my life, and now I have none. One more voice. This is a note written from a participant to her addiction. All you do is make me sick, and one day you will surely kill me if we ever meet again. Regrettably, that's exactly what happened to her. She returned to use and OD'd. And that's what happened to the other 2 as well. My friends, this is serious business. It always has been, but it is for real now. Thank you for your commitment to doing everything you can to keep people alive and well until drug court works. Thank you. Enjoy the rest of your conference. Your next session starts at 9:30.